Assalamu alaikum. Today I would like to talk about approach to hyponatremia. Okay, look at this 33-year-old woman comes to you with generalized tonic-clonic seizure. Sodium is low, so we know that sodium for CNS. So low sodium hyponatremia cause CNS feature generalized tonic-clonic seizure. Lungs are clear, heart sounds are normal. Okay, sodium low, calcium bit low or closer to normal. Sodium low, then look at the serum osmolarity. Serum osmolarity is less than 290, so it is hypotonic. And now the urine osmolarity, and urine osmolarity is less than 100. So serum osmolarity is low, serum serum sodium is low, serum osmolarity is low, hypotonic, and urine osmolarity is less than 100. Which of the following is a most likely electrolyte abnormalities in this patient? Looks like it is primary polydipsia. Why? If we read this flowchart, then we can remember this, that if somebody has serum sodium, like if somebody has hyponatremia, evaluation of hyponatremia, first do the serum osmolarity. If serum osmolarity is more than 290 milliosmol per kg, if serum osmolarity is more than 290 milliosmol per kg, it is AM, like advanced renal disease and marked hyperglycemia. So if serum osmolarity is more than 290, then it is AM. Then if serum osmolarity is not more than 290 milliosmol per kg, no, do urine osmolarity. If urine osmolarity is less than 100 milliosmol per kg, yes, then go for PM, like primary polydipsia and malnutrition, beer drinker or proteinuria. So AM goes, PM goes. If you are unable to diagnose, like urine osmolarity is less than 100 milliosmol per kg, urine osmolarity is no, not urine osmolarity is not less than 100 milliosmol per kg, then do urine sodium. If urine sodium is less than 25, if urine sodium is less than 25 milliequivalent per liter, yes, it is VCC, volume depletion, congestive heart failure, and cirrhosis. And if urine sodium is not less than 25 milli or equivalent per liter, that means if serum urinary sodium is high, if urine sodium is high, then SIADH, adrenal insufficiency and hypothyroidism should be thought. Then hypothyroidism should be thought. So these patients' seizure due to hyponatremia. In here, we found the serum sodium is low, serum osmolarity is less than 290 milliosmol per kg, and urine osmolarity is less than 100. So urine osmolarity is less than 100. Yes. So there is two differential, like primary polydipsia and BR protomania. Primary polydipsia is the most common in psychiatric condition schizophrenia, possibly due to central defect of the thirst regulation. And these patients continue to drink despite decreased serum osmolarity that normally inhibit the thirst reflex. The kidney increases water excretion, which dilutes the urine, making to an osmolarity less than 100 milliosmol per kg. Okay. look at this question. Again, serum sodium is low. Serum osmolarity is not done. Okay, serum osmolarity is less than 290 milliosmol per kg. If serum osmolar and urine osmolarity is more than 500, so urine osmolarity, so serum osmolarity is low, less than 290 milliosmol per kg. Then and urine osmolarity is higher. If urine osmolarity is higher, like more than 25, then there is three causes: SIADH, adrenal insufficiency, SIADH, adrenal insufficiency, and hypothyroidism. If urine osmolarity is not less than 100, if urine osmolarity is more than 100, like 500, then you should think about the sodium. If urine sodium is higher, then think about three causes: SIADH, adrenal insufficiency, and hypothyroidism. If urine sodium is lower, like less than 25, then there is volume depletion, congestive heart failure, and cirrhosis. Okay, so it is SIADH, adverse effect of the drug, and in here there is a drug history is present which is causing this, like this sertraline is causing. Sertraline is a SSRI, so it can cause the SIADH. Okay, finally look at this question. So first serum sodium, then serum osmolarity, then urine osmolarity. Okay, and in here hypertonic saline is planned for gradual correction of the hyponatremia. Okay, so this patient with unremarkable CT scan of the head experienced a seizure likely due to hyponatremia. Okay, in hyponatremia there is isotonic hypertonic as serum osmolarity is, if serum osmolarity is less than 290 milliosmol or less than 275, so it is hypotonic. If it is isotonic or hypertonic, the osmolarity would be higher, and in hypertonic it may be due to translocational hyponatremia like hyperglycemia, and exogenous solute like mannitol, and isotonic like pseudohyponatremia, paraproteinemia, and hyperlipidemia. Then you should go for the ECV, extracellular volume. In extracellular volume, is it hypovolemia? Is it euvolemia? Is it hypervolemia? So we need to see the volume status. In hypovolemia, then we should do urinary sodium. If urinary sodium is less than 40, non-renal, 40, less than 40, non-renal salt loss, it may be due to vomiting and diarrhea. It may be due to vomiting and diarrhea. And if urine sodium is more than 40, it may be due to renal salt loss like diuretics and primary renal insufficiency. If it is euvolemic, then urine osmolarity is less than 100 milliosmol per kg. It is PM, like primary polydipsia and malnutrition. If urine osmolarity is more than 100 and urine sodium is more than 40, urine osmolarity is higher, urine sodium is higher, it is SIADH, and hypervolemic is heart failure, cirrhosis, and nephrotic syndrome. So urine osmolarity measures we can differentiate the primary polydipsia with SIADH. If there is low urine osmolarity, reflects massive water ingestion leading to dilute urine. Massive water ingestion leading to dilute urine. This finding is consistent. So low urine osmolarity, which reflects massive water ingestion leading to dilute urine. This this finding is consistent with primary polydipsia and high urine osmolarity. That means mm, water being pulled out of the urine in response to ADH. Water is pulled out to the urine in response to ADH, resulting in concentrated urine. This finding is seen in the excess ADH, SIADH. So polyuria is another factor that can help in diagnosis between these disorder, primary polydipsia and presence in primary poly absence in SIDS, but confirmed polyuria in a timely manner can be difficult, limited ability to establish a history in this patient, making immunoosmolarity particularly helpful. Okay, so that is the way of evaluating hyponatremia. I hope you enjoyed.